Be that way. But there's going to be a little bit of hold on. Here. Oh, girl, I'm going to say 5:40. Hopefully around 5:45. I have an appointment on non-lactation. Oh, I can't really say anything that time. Yeah. Okay, that's fine. Yeah. It's a document, and it's very exciting. No, it's Interprofessional Health Association, and they have a movie. It's like open prescription drive every in a town in Virginia. And that's what our coalition is about. So I'm not sure, and it looks really good. I thought it was you heard that too.
Yeah, sometimes trailers go down. Sometimes the trailers don't
Sorry. I don't know. It's like
Oh, we've already got it. I got
Anyone need to find where?
Oh, yes. I'm sorry. I remember this. Once again, we're being recorded. Everybody loudly so that your colleagues can understand what's going on as they listen to our recording. My little slide here. I didn't catch the undo, but anyway, epidemiology in the news. Something startling is happening to middle-aged white Americans. Unlike every other age group, unlike every other racial and ethnic group, unlike their counterparts in rich countries, death rates in this group have been rising. And so Monday, actually, a report from two economists from the United States were analyzing health and mortality data from the Centers for Disease Control and Prevention, and they concluded that rising annual death rates among white Americans, men, particularly men, whites ages 45 to 54 years old, were increasing by 134 deaths per 100,000 people from 1999 to 2014. And that is just absolutely startling for a country like the United States to have such a significant increase in deaths. And the rising annual death rates among this group, once again, whites ages 45 to 54, that's a young age group in terms for the United States, considering our life expectancy. And the rates are not being driven by the big killers like heart disease and cancer. What do you think, or did you hear this report? What do you believe is attributable to this increase in death rate? Not the biggies, not heart disease, not cancer. Yeah.
I read this. I don't remember much of it, but was something in there about their education status?
Yes, good point. In terms of characteristics of the individuals, the declining health and fortunes of poorly educated American white. And so, good point. And because of the contextual variables of poor, less educated, the deaths are attributed to, you had your hand up?
I've also read it.
Yeah.
It mentions that there's a correlation of like substance abuse, suicide, and all of those different things come from them like not coping well.
A big influence of their environment. Epidemic of suicide, afflictions stemming from substance abuse, alcohol, liver disease, and overdoses of heroin and prescription opioids. And so huge finding here. Now, actually, this was a report from two faculty members at Princeton. They're both economists. Angus Deaton, who just happened to win the Nobel Memorial Prize in Economic Science just last month, and his wife Ann Case. But we're using data available to all of us from the CDC, vital statistics data, and looking over time as to what's happening to these rates. And I apologize I was trying to get the actual figure or graph in there, and obviously I was not successful, and I thought I took it out, but I did not. Any other news item? Yes.
There's an E. coli outbreak in Oregon, and it's affected 43 people so far, and apparently it's still on the rise, and it's from Chipotle.
Yes. And when you said Chipotle, you looked distressed. What is that? There you go. Someplace that you may go. And right, they are known for their sort of sustainable practices and going right to the farm to get their meats and produce. And but yeah, they're believe closed down 20 or so locations in Oregon, and I think also maybe Northern California. Yeah. Anything else? Yes.
There was a confirmed case of bubonic plague in Washington, but they've actually they found the source and they contained it.
Okay. And what was the source?
The source was either a deer tick or a deer flea. It was something in deer hunting. That's what they had been.
Oh, flea. I think it was
Okay.
Oregon.
Was it Oregon? It was Oregon or Washington?
Yeah.
Okay. Oh dear, Oregon's heavy. Interesting. Anything else? Sort of fascinating cases. Now you guys understand it all. Okay. Last week we discussed causation and allowed us to really begin to get into the field of epidemiology. Now we're looking at etiology, causation. This week, today, we'll discuss what epidemiologists are known for, how we contribute to particularly study design, critiquing the literature, having command of what is bias, when does it occur, how to control for it, same thing for confounding, and then a discussion of interaction. But just a little review from last week, causation, where we have factor A, B, or C can each individually cause a certain disease or an outcome without the other two factors. So we've got A, B, and C, but only when followed by exposure to factor X. And so I remember talking a little bit about how the time sequence is often important in terms of what an individual might be exposed to or not exposed to. But exposure to factor X alone is not followed by the disease. but the disease never occurs in the absence of exposure to factor X. And so what is factor X in terms of A, B, C, D, or E, and justify your response? Yes.
X is B, necessary but not sufficient, because it has to be present in order for the disease to occur. It is necessary, but X alone is not sufficient to cause the disease.
Okay.
It's not.
Okay. And so can you inform us a little bit more or give us a helpful hint as to how you selected your answer? What helped you to select that response? How did you parse out the information provided to you?
Factor A, B, or C needed to be present in conjunction with X, so X alone isn't causing the disease. That means it's not sufficient. But in every situation, X has to be present for the disease to occur, so it's necessary.
Okay. Okay. All right. Good. Thank you. That's very helpful. I know what I'm doing. Okay, that was factor X. Now let's go to factor A. Same information on the left, but now we want to know about factor A and take a look at that and see what response is most appropriate for factor A and why.
Would it be B?
Go ahead and tell us your train of thought.
So A, B, or C could be present. So therefore, just A isn't necessary. It could be B or C, so it's not necessary. But it can't work by itself. It has to also have X, so it's not sufficient.
Any other thoughts? Do we like that? Okay. All right. Very good. Okay. I think those are in the end of the chapter or something like that. But anyway, folks are looking for additional exercises sometimes to help prepare yourself, for exams. One thing you might think about is it doesn't necessarily matter what the numbers are, but it's the approach, your thought process, and how you are using the numbers. And so do the questions at the end of a chapter on one day, skip a couple days, go back and redo them. Go through the quizzes, and then skip a couple days and go through the quizzes again. Okay, like I said, the numbers don't matter. It's your thought process and how you are thinking about, you know, where to place this information. For example, if you're thinking about a 2x2 table, what goes there? How should my 2x2 table be arranged? That's the important part of the task or the activity. Not necessarily what the numbers are. And then once again, in terms of the calculations, if you, even for the exercise 3 that we have, or for the next exam, as long as you place the numbers in the, you know, A is divided by B or whatever, that's fine, and not calculate it all the way to the end. We just want to make sure that you're using what you have appropriately. Okay, now as I mentioned, we're going to start discussing bias, confounding, and interaction. Really tough terms to get a command of how they're different, why they're important, what we might do with them. And so if you went through the chapter and you were perplexed the first time around, that's okay. And so let's work on our understanding a bit more today. One of the primary tasks that we are given as we design a research study or develop an intervention, conduct an analysis, is trying to exclude as much potential error that could occur. We want a robust study, we want a clean study. We want to make sure once we get to the end of our study, the data are collected, that we can use the data that have been collected. And so in terms of error, as we discussed in epidemiology, there's two types of error: random or systematic. Okay. Random error is always going to exist, and there's nothing that we can do about it. Okay. Random, it's out there. We just know that it potentially can occur. Systematic, because it is systematic, we can control for systematic error. And in terms of study design, we can control for systematic error either during the design phase or the analysis phase. And so we will talk about that a little bit, sort of a figure of bias coming into town, and misclassification and selection, and bias in how we measure exposure, bias in how we might classify a case versus a control, bias in how we might classify an exposure or not an exposure. So as I was mentioning, our goal is to make sure that we are conducting valid and reliable studies. And so sources of error, we have random error and systematic error, which is both bias and confounding. Bias and confounding fall into the category of systematic error. Once we are able to state that our study results are not due to any of these errors, then we can say that our study is internally valid. Okay, we've discussed the issue of validity. Internal to the study, is the study, does it have internal validity within the data that we have collected? We wanted, that's step one. We want to make sure that our data are internally valid before we make any generalizations to our target population. We have an example here to set the stage. The Physicians' Health Study concluded that aspirin use reduced the risk of MIs. heart attacks in adult male physicians in the United States. It was one of the inclusion criteria for the Physicians' Health Study. A large study conducted was that the physicians be male. The study was carefully done. The study was internally valid, but it was not clear that the results could be extrapolated to women or even to non-physicians. But in order to make any generalizations, first needed to show or to demonstrate that the study had internal validity. And so, as we are proceeding through the principles and concepts of the basics of epidemiology, we've learned something, and each time we meet, we're beginning to pull all of these concepts together. And so, even though we're primarily discussing bias and confounding interaction, it's important to see how they are used to demonstrate internal validity and as a long-term goal of external validity. Okay, so random error, systematic error, bias is a systematic error, and it can, if it does exist within an epidemiologic study, it can lead to spurious results. There are methods to control bias, and so the planning stage of a study is the most important phase of research. Anyone can collect data, but we want to make sure that our data are collected according to procedures that will allow us to reduce potential bias in our study. The bias could be associated with the method of data collection. We may send untrained interviewers out into the field, and they may have not following a standard procedure for interviewing, they may actually influence the data that are being collected. They may probe a little bit more for information from cases versus information from controls. So we are not, when we don't treat the cases the same way as the controls, bias could enter into the study. And so one way to reduce potential bias in that situation is to make sure that we have a good, strong training procedure for staff that are working on collecting data. We may have use certain type of instruments to collect our study data. It may be something as simple as bringing out a scale into the field where we want to get the weight of our study participants. And as that scale is used over the months, it may be a longitudinal study, it may lose its calibration. As it loses its calibration, we may get into the problem of misclassifying our study subjects. If weight or BMI is an important independent variable for our study, there may be errors in classification of our study participants. There may be errors in classification of our outcomes. Perhaps we're in the field and we're studying an intervention that we hope to reduce weight in cases versus controls, or intervention versus non-intervention groups. We have a measurement tool, our scale that's going out of calibration. We may, in the end, wash out any differences between our groups because we have a biased estimate of our outcome based on our scale that should have been calibrated as the study was going on. Well, once bias has been introduced, it can't be removed. We may be able to adjust for it, but we can't remove it. In the case of using a non-calibrated scale, we don't know when it went out of calibration, by how many units over time it was going out of calibration. And so, once again, the efforts to control for bias during the design meaning having a procedure in one procedures manual that every time the scale comes back to the study office, it is calibrated. We've read a little bit about selection bias and information bias. Bias and confounding are two different things, okay? Confounding is not a bias. While it may do something similar to our data in terms of having an effect on estimates of association, you can adjust for confounding in the analysis. And we'll discuss more about that. So let's think about one type of bias, a selection bias, an important aspect of a cohort study, case control study. We want to make sure that the process of selecting subjects, for identifying subjects, or even establishing the operational definition of our subjects for our study is sound. We do that so that we can make sure that selection bias doesn't enter into our study. Selection of subjects into a study, or their likelihood of being retained, particularly important for a cohort study in terms of retaining subjects once we have difficulties with loss to follow-up attrition. That's a bias that enters our study. Once we lose our study subjects, we can no longer get them back. That has an effect on our internal validity of the data that we're collecting. Once that happens, the study leads to a result that is different from what you would have gotten if you had enrolled the entire target population. A question that we have when we're critiquing the literature in terms of a particular study. What was the retention rate? What was the loss to follow-up rate? What was their consent rate? What was the proportion of subjects who were asked to be in the study actually joined the study? Important questions to assess bias, to learn whether or not the results from the study are useful. If the majority of the individuals that you ask to participate in your study do not participate, then those that do participate in your study are not representative of the target population of bias. And so you remember, we're never studying the full population. We don't have the time, we don't have the resources to do so. And so our studies are based on samples of our target population. And so we want to make sure that we have fair sampling. In terms of our 2x2 table, which includes diseased and non-diseased, exposed and non-exposed, we want to make sure that the sampling in all 4 of those cells is fair and representative and equal. All the ladles are of the same size. Now, if the sampling is not representative of what is truly happening in your target population, that's when you start getting into the situation of disproportionately sampling. The disproportionate sample does not represent what is actually occurring in your target population. So you want to make sure that your proportion of exposure, non-exposure, disease, not disease, is similar in your study population versus your target population. And so selection bias could occur when the enrollment procedures result in a disproportionately large sampling of diseased subjects who had the exposure. Okay, so you can see that this could affect your odds ratio, for example. Odds ratio is based on your study subjects that fall into the 4 cells of your 2x2 table. And if selection bias enters into the study design, it then leads to results, outcome measures that are not true, not correct. So how does selection bias occur? What are some of the mechanisms that lead to selection bias? Here's some examples of how selection bias can occur. Selection of a comparison group, your control, that is not representative of the population that produced the cases in a case control study, is a control selection bias. Okay, so you have your cases. Remember, your cases are those that have the disease, have the outcome. And if you select your cases from a certain hospital or a certain clinic, and then you select your controls from the general population, you may have a control selection bias because the folks that are from the hospital or the clinic may have been referred from places other than the general population. Let's say that we're in the United States. This is a very famous clinic, the Mayo Clinic, that receives referrals from all over the world. If your control group does not include a similar population as those who potentially could be referred to that clinic, then you would have a control selection bias. If you have a differential loss to follow-up in a cohort study, such that the likelihood of being lost to follow-up is related to outcome status and exposure status, then you might have a loss to follow-up bias. Okay, so we are constantly checking for, okay, we know we have loss to follow-up overall for our study. Does it differ between our exposed group versus our non-exposed group? Okay, whenever we start seeing differential proportions between our groups that we're trying to compare, we need to check into that and make sure that it is not a bias or a potential bias. If we do find a bias, we need to state that as a limitation to our study. We don't try to hide it. Things happen. These are human subjects that we're dealing with. Refusal, non-response, or agreement to participate that is related to the exposure and disease. Self-selection bias. If you're conducting a case control study, you often will have a higher response rate, a higher agreement to participate among the case group because they're invested. They know they have the disease. They want to know more about the disease. They're not sure why they have the disease, and so they want to participate. They want to provide you with as much information as possible, whereas to control, they don't have investment in the topic of the study. They don't have time, and so there may be a differential agreement or response rate between the cases and the controls. And so another thing to be aware of up front, and knowledge of this allows you to think of procedures that will help you to attain the same type of response or agreement from the two groups that you're eventually going to study. Using the general population as a comparison group for an occupational cohort study, also termed the healthy worker effect. Individuals that work, are employed, are in general healthier than the general population. Individuals that are disabled, have a disease, often cannot work. And so you see that the using the general population as a comparison group is not a fair comparison. You may never see the difference that you want to see if you're looking at a certain exposure. Your general population rates of disease may always be higher than your occupational cohort, just because your occupational cohort may be healthier, or the general population is unhealthier than the employed workers. And then another mechanism towards selection bias may be a differential referral or diagnosis of subjects. And let's see if we have an example of, we'll have an example of that a little later on. Selection bias in case control studies. Selection bias can occur in case control studies. Selection bias can occur in cohort studies. And so selection bias in general can occur in all of the study designs that we have discussed thus far. Cross-sectional studies, primarily you are concerned about, once again, the percent of your target of your sampled group that actually participates. So selection bias in case control studies, let's be more specific to that type of design, can occur when subjects for the control group are not truly representative of the population that produced the case. Okay, remember, your cases and your controls should be exactly the same, except the cases has the outcome or the disease, and the control group doesn't. Otherwise, they should be the same. And so if you have a disproportionate agreement or identification between cases and controls, then you're going to be introducing selection bias. The controls are used to estimate the exposure distribution in the population from which the cases arose. Because remember, just because there's an exposure does not necessarily mean that an individual will be a case. You've got that baseline level of exposure that's always in the general population. This is why we have the control group, so that they can represent that exposure distribution. And what we're trying to find is that added amount of exposure that leads to cases. And then in terms of case control studies and selection bias, the exposure distribution in cases is then compared to the exposure distribution in the controls to compute the odds ratio as a measure of association. Once again, tying all of this together, trying to make sure in your design that you're controlling for your selection bias, so you then can fill in your 2x2 table, and you can end with the calculation of odds ratio. So we are trying to avoid bias that will potentially contaminate the results, lead to spurious results of our study. Back to our ladles and another description of potentially how selection bias can occur with the larger label under the controls indicating that non-disease subjects with the exposure were oversampled. Once again, an illustration how the sampling or the selection bias can lead to an underestimate or an overestimate of relative risk, for example, or your odds ratio. So with a specific example, disease subjects who had the exposure and a participation rate of 80%, the other three categories had participation rates of 60%. So what you want to want your labels always to be the same size. we're looking at participation rate in one group higher than the participation rate in your other group, comparing disease subjects who had the exposure versus the other three categories, disproportionate rate of participation can lead to selection bias. Yes.
I'm following along with this PowerPoint as well as the other PowerPoint, but in reading the selection bias in this PowerPoint and the example, I was wondering if I don't understand the example that's in this PowerPoint.
Okay.
Yes, actually.
Okay, sure. And what we're showing in this PowerPoint here is that the participation rate among the individuals that were sampled for participating in the study was not equal. Okay, and so we have a target population, all right, and we know that in a target population, there's a distribution of exposure, okay? We want our sampled population for our study to have the same distribution of exposure, okay? In this pictorial, it shows that more individuals that were diseased and exposed participated in the study. And so they did not that did not represent the distribution in the target population. So if we use the results from this picture, it's not going to be a correct result, a correct representation of the target population because of the way that the subjects selected themselves for participating. Yes?
Can we adjust for that? It's just a difference in percentages, right? Couldn't we use a standard population and adjust it? Is that doable?
We could potentially, if we knew exactly what was going on. Okay. Sometimes we don't. What we really want to do is have a clean, clear design phase where we're making sure we're trying to attempt to reduce our biases in the design phase. Once we get to the analysis, we're often making guesses, and we cannot do it as cleanly. You want to address bias during the design phase. It's easier to address confounding in the analysis phase. With bias, it's more difficult. We try to do that in the design phase. In terms of things that can go wrong, that you need to think about when you're in the design phase and developing your procedures to attempt to do reduce bias, you want to make sure that differential anything is not occurring. Differential, in this example, differential surveillance, differential referral, or diagnosis of subjects. Sort of an interesting series of events here. Case control study to investigate whether the use of oral contraceptives increase the risk of embolism. Okay. Case group was women who had been admitted to the hospital for embolism. Okay, the case group was in the hospital. Control group was women hospitalized for unrelated problems at the same hospital. Okay, so at least we're sort of getting around the issue of, all right, where are these women coming from? Well, at least they were all referred to the same hospital. Okay. Interviews indicated that 70% of cases used oral contraceptives versus 20% of controls. Well, what was happening, healthcare providers had heard that oral contraceptives were potentially associated with the outcome here in terms of embolism. And so they then were more likely to admit them to the hospital if they developed signs or symptoms. They were being cautious. And so as a result, the study had a tendency to oversample women who had both the exposure and the outcome of interest. Okay? Just because the way that there was a differential reason why the women got into that same hospital. And so, once again, we are trying to determine and trying to control for cases being treated differently than controls. Okay, and so in this case, women that were not on oral contraceptives and had developed signs or symptoms of thrombosis were not necessarily referred at the same rate as women who also had that exposure to oral contraceptives. And so that was throwing off proportions, how they existed in your target population versus the population that was being used, the population in the hospital that the investigators were using for the case control study. So we need to think a little bit differently about selection bias in cohort studies. Factors affecting enrollment of subjects in a prospective cohort study would not be expected to introduce selection bias, okay? Selection has to be related to both the exposure and the outcome. Remember, in your prospective study, you most often don't know what the exposure is, or at least the subject does not know that they've been have the exposure. You're going prospectively over time. You're potentially defining your exposure after the study has started. However, your retrospective cohort study could potentially have selection bias, something that you should think about as you are trying to design the retrospective cohort study. How could you reduce selection bias? And something to keep in mind as you're reviewing the literature, trying to gather documentation for whatever area you're interested in, whatever area you're studying, and whether or not you should rely on such a study because it may not have internal validity due to selection bias. Let's see. I'm not showing that right now. But will be in your, not showing well on the screen. So rather than confusing folks, we'll go back to those later on. Loss to follow-up. Another process that can potentially lead to bias in prospective studies. As I mentioned, once again, during the planning phase of study where you're writing or developing your manual of procedures, your operations manual, you want to think about including steps, activities, procedures that will help you to reduce potential bias. You're going to do a prospective study. All right, what can we do to try to prevent loss to follow-up? Enroll, some suggestions, enroll motivated subjects, use subjects who are easy to track. For example, screening for potential subjects for a longitudinal study, and you are doing it in a certain geographic area. One of the screening questions may be, and your study's going to go for 5 years, one of your screening questions may be, do you anticipate moving within the next 5 years? They say, oh, yeah, you know, we're going to be moving within a year. Then that may be a subject that you do not enroll in your study. You want to make your questionnaires easy to complete. Well, a general statement is you want to think about the burden of participating. You want to make it easy for your subjects to participate. You want to give them options in terms of where would they like their study visits to occur. Is it easier for them to be at home? Would they like to meet you somewhere? Can you meet them after work? Always need to anticipate participant burden, and that's why we so often pilot all of our activities that we're thinking of including in our final protocol so that we can get feedback from individuals that will be like the individuals that will be enrolling in our subjects, and with that feedback, change anything that we may need to change, because we do not want to lose subjects because of something that we have incorporated into a protocol. You want to maintain the interest of participants and make them feel that the study is important. When we were discussing our children's health study of follow-up for 21 years, our potential subjects knew that their participation would potentially not have an influence on their own child's growth, health, or development, but they were thinking about perhaps they were going to be expanding their family. It could have been for future children, for future generations. The fact that they were participating in a national study, that others would hear about it, that they were contributing to their community, they were contributing to the nation. It often surprised us how they were informing us how the study was important, things that we didn't think about. And so that constant dialogue, constantly having communication with your study subjects, providing them feedback on questionnaires that they might fill out. They want to learn from you, and you need to keep them invested in the study so that both sides will feel that it is a successful run. Provide incentives. Incentives are always helpful. It does not need to be monetary incentives. Non-monetary incentives work very well. As we were enrolling our pregnant moms into our studies, we often provide them with with go bags, bags that they pack, they take to the hospital with them. We provide them with toys or blankets for their babies, non-monetary things, just to show them that we appreciate their time, their effort, and most importantly, their data. So there are things that can be done to reduce potential bias. Knowing what bias is, knowing the types of bias, and then what can you do in your study, or what should the investigators have done in a study that they have published that could have reduced the possible effect of bias. Mention the healthy worker effect. The important points of those who are not healthy are less likely to be employed, and the employed workforce tends to have fewer sick people. So once again, you have a differential distribution of disease or outcome in two populations. Because of that, you don't want to compare them. People with severe illness might be excluded from employment, but certainly not from the general population. And so comparisons of mortality rates between an unemployed group and the general population most likely will be biased. Another type of bias, a large category, information bias. There are, then once you have information bias, you can have many different categories of information bias. And so, for example, we had selection bias. A category under selection bias could be self-selection bias. Information bias is an observation bias, non-differential or differential. For exposure misclassification, the misclassification is non-differential if it's unrelated to occurrence or presence of disease. If the misclassification of exposure is different for those with and without disease, it's differential. Okay, and same case for misclassification of disease is non-differential if it's unrelated to exposure. Otherwise, it's differential. And, you know, once again, it's, if you're treating the exposure or measuring the exposure in the same way for both the cases and controls, even if it's an incorrect way to measure exposure, you're measuring it the same in the cases and controls. Okay, so it's non-differential. And that's what you want to do. You want to make sure that you're measuring the exposure in the same way for the cases and controls. You're measuring disease in the same way for the exposed versus the non-exposed. You want to deal with whatever groups you're comparing and use the same procedures for those two groups that will eventually be compared. How does one get misclassification? There may be differential and recall in terms of if you want to classify subjects into exposure categories, you're going to have discussions, interview your cases and controls, and ask them about the exposures they may have had in the past 5 years, the past 6 months, the past 10 years. There may be differential recall among cases and controls. And once again, it's because of the cases being a case that's on their mind. They are, once again, invested. They're trying to provide you with complete set of information on exposures, whereas your controls may not. So how do you get around that? use a control group that has a different disease, okay? So they're not quite sure what specifically you're after, but they know that they have a disease, and they would potentially have a similar recall as your case group. Use questionnaires that are carefully constructed, and perhaps best is having, once again, pre-existing records that document the exposure, and you don't even have to ask the cases and controls, but you can actually go to something that exists, something that was recorded in the past, or access to past exposures from biomarkers. We often construct case control studies using biobanks, banks of specimens that have been stored in the past. Now we've got a new question that we want to answer. We can go back, rather than asking individuals about potential exposures in the past, we can use the specimens to measure certain biomarkers, whatever. Interviewer bias can also lead to misclassification of specifically exposure. When there are differences in soliciting, recording, or interpreting information on exposure or in outcome. It's best to blind your interviewers to whether or not they're interviewing a case or a control, so that they don't introduce that sort of internal bias that will then potentially lead to differential misclassifications of exposure. So we've discussed two primary categories of bias: selection bias, information bias. It can occur in any study design, and so we need to be aware that that is a potential limitation to our study. It's best for us to attempt to reduce bias during the design phase, meaning what is the best method of collecting data so that we can have retain internal validity in our study and be able to generalize it to our target population. And so a very, very quick overview of bias, and let's take a break and reassemble at 2:15, and we'll continue with confounding and what else are we doing today? Interactive. I think you're wrong.
I was like, whoa.
Sorry. I get an art for the R word, so since they already, since they allow that. You ready?
Yeah.
Sorry about that.
So, are you coming to the right? Yeah. Hang out and watch with us.
Oh, when is it?
Saturday night.
Oh, right now, right now. Write it down right now.
Right here in Microsoft is downtown, and I ordered it. It's like 10 or 15 of us.
Okay, I'm writing it down. This is mine. Where's my pen? Just kidding, yeah.
There's something happening at the Willow Tree right before that. So like 8 to 10 to the light start, but then it's free light forever.
Right, exactly. Yep.
I'll text you. Great, thank you.
Yeah, that's fine.
Yeah, did you see it? We were out there yesterday playing around. Feel a little sort of white dog. My cat and we're going to send out Christmas cards. Oh,
very serious.
So like, I know they're not, but I have to get like a puppy because I know. He was yeah, I don't know.
Oh, really? Yeah, but by the time
Monday.
Yeah, my brother, I think they like looked for a match. I was like, I'm well socialized with someone there at school. They do the same thing as like we have. I know. I always forget it. It's a very big I know they can do chat and training classes because they got like yeah. Yeah, it's really done really good. No, I think it's just like don't get up on the counter, don't clear stuff up, no biting, no scratching, that kind of thing. Me too, I have to like stay at home and study hard. So we either outside or like oh yeah, that'd be good for him. I can't like take him along like okay, let's continue. Or something while going to the Navy and
Someone mind just closing the door just a little bit. Does anyone need the fan to be out? Are you all set?
traumatized.
You all set? Yes, no. Fan? Yes. You need the fan. Plug it in. Okay, confounding. A distortion of the association between an exposure and an outcome that occurs when the study groups differ with respect to other factors that influence outcomes. What is the most important two things that you need to remember about whether or not you have a potential confounding variable? It needs to be associated with the
Cause and outcome.
That's right. A confounder must be associated with the exposure under study and it must be associated with the outcome under study, okay? Two very important aspects of confounding. If you don't remember anything else, those two pieces of information will get you some points. Yes. Well, certainly can. A confounding variable must be associated with the exposure of interest or understudy. Okay. It also must be associated with the outcome of interest for the outcome understudy. And so that is what is depicted here. We have the potential confounding variable age, and with the arrows at both ends of the dotted line, this is demonstrating that age is associated with physical inactivity, with the example given, older individuals may exercise less. And so if you have two populations that you're comparing, and you have a differential age distribution in those two studies, you could have an invalid conclusion if you do not take into consideration the potential confounding variable of age. If you are studying heart disease, because age is also associated with heart disease, and older people have more risk of heart disease. Okay, so this is a very important diagram to think about and to understand. What we're saying here is that the confounding variable in this diagram is age, because age in this situation where we are asking if physical inactivity is on the causative pathway to heart disease, we need to consider the potential confounding effect of age. Age is associated both with the exposure. The exposure here is physical inactivity, and age is also associated with heart disease, our outcome. Okay, the two things that are needed in order for a variable to be labeled as a confounding variable. And then reasons below why age is important for both the exposure and the outcome of interest. Any questions about this diagram? Okay, once again, for confounding to occur, the potential confounding factor must be associated with both the primary exposure of interest and the disease outcome of interest. And so this diagram is showing you that fluid intake is associated with physical inactivity. It does not, however, have a double-pointed dashed line between fluid intake and coronary heart disease. Okay, and so it doesn't meet the two criteria for being a confounding variable. fluid intake is not a confounding variable in this diagram, okay? This is helpful to know because we don't, if we're studying physical inactivity and coronary artery disease, in the design phase, we don't have to collect information on fluid intake. Or in the analysis, if we did have information on fluid intake, we would not need to include fluid intake as a potential or adjust for fluid intake because it's not a confounding variable. So what we try to do in the design phase is think of all the potential confounding variables that are associated with our exposure and our outcome and collect that information up front so that we can use those data during the analysis phase to control for the confounding effect. Sometimes we do not know what all the confounding variables are, and that is sometimes a limitation of our study. We just did not collect data on a potential confounding variable because we did not know that it was a confounder. Whoops. Okay, once again, conditions necessary for confounding. The confounding variable must be associated with both the risk factor of interest and the outcome. The confounding factor must be distributed unequally among the groups being compared. So what does that second point mean? Let's go back to the original diagram. The confounding factor must be disproportionately distributed among the two groups. And so we have older people versus younger people exercise less. Older people versus younger people have more risk of heart disease. That means that the potential confounding factor of age is disproportionate in our exposure, disproportionate in outcome. A confounder cannot be an intermediary step in the causal pathway from the exposure of interest to outcome of interest, okay? Here we have this straight line. We have an intermediary from alcohol consumption having effect on the level of your HDL, raising it, increasing it, with an outcome of a decrease in heart disease. HDL is not a confounder between alcohol and heart disease. It's part of the mechanism from alcohol consumption to heart disease. Alcohol, moderate intake of alcohol producing higher levels of the, quote, good cholesterol, leading to reduction in or protection from heart disease. So a third piece of information we now know about a potential confounding variable associated with the exposure, associated with the outcome, and cannot be an intermediate step between exposure and outcome. And so we identify confounding by comparing outcome measures, measures of association, before and after, with a caveat: if we find a difference between our two measures of 10% or more, then we can comfortably or uncomfortably state that we have identified confounding. And so let's look at ways in which we can quantify that using measures that we are familiar with, measures that we have used, both crude and adjusted rates. Does everyone remember what the crude and adjusted rates are? Some operational definitions. What is a crude rate? No. Crude rate.
Before you do anything with it.
Okay.
Before you
Before, right. It's using the data as is. Crude rate. I'm sorry.
No, on this list, without an adjustment.
Without an adjustment, it's the number of, if we were talking about mortality, for example, the number of deaths in a population over the total population, mid-year population. Crude, we're using the numbers, and then we can adjust for, why would we want to adjust? When we're comparing two populations, for example, and we know that age distribution differs between the two populations, so we can adjust for age. Is the adjusted rate the true rate in that population? No, it's the hypothetical rate because it's been adjusted using a standard. And so we have this sort of interesting, a method favored by biostatisticians, a method favored by epidemiologists in terms of calculating the magnitude of confounding. You have your crude rate minus your adjusted divided by your adjusted.
So is that the one that you want us to know for the epidemiologist?
That's the one I want you to know. Yes. So let's stick with the epidemiologist. Good question. Just to let you know that once again in your discussions with your colleagues, you may be presented with the crude minus adjusted divided by crude. It's also appropriate, and usually the results are quite similar. So controlling for confounding, we want to control for it because once again it can potentially bring in error into our study design. It can bring error into our data analysis, and it can bring error into the conclusions of our study. And so during the design, there are some steps that we can incorporate into our manual of procedures. If we think that age is a confounder, we can restrict on age. For example, we may not want to include adults 21 to 75. We may restrict to individuals 60 years of age and older, and so that would get away from our comparison of young versus old. if we think that age is a confounding factor. Or we may want to use matching to control for confounding. And then we attempt to control for confounding by using randomization if we're conducting an experimental study, whether or not it be individual or a community-based experimental study. Does randomization always control for confounding? No, I seem to remember a question on during the first exam. Randomization is used in an attempt to make your two populations equal, but it may not always work. And so if it doesn't work during the design of the study, if you use the procedure of randomization and you compare your two groups and you learn that they do have a differential distribution, for example, in age, you can now try to control for confounding during the analysis. So you sort of get 2 attempts to clean up your study during the design or during the analysis. In terms of during the analysis, what does stratification mean? Well, basically, it's I will ask the same question for the younger age, and then I will ask the same question for the older age. That's one way to control for age. I'll put all the similar study subjects in one pot and do my analysis. That's strata A, and then I put my older study subjects in another pot, strata B, and do my final analysis and determine whether or not there's a difference in the outcome between strata A and strata B. Yes?
I thought stratification was like kind of a type of design.
Stratification can be a design. We can have a stratified randomization scheme, but we can also have a stratified analysis. Okay. It's a similar concept. Stratified randomization, for example, we might, same thing, select, dichotomize our age groups, younger, older, and then run a randomization scheme within the youngers, run a randomization scheme within the olders during the design, or we can do a similar stratification during the analysis. So great, thanks for that question. Or during the analysis, multiple variable regression analysis, where you are entering your potential confounding variables, your mediator variables, your covariates, whatever, your independent variables on the left-hand side of your formula and controlling for confounding that way. So control of confounding can occur during the design and it can occur during the analysis. Okay, so what do we need to know? What are the 3 things that we need to know about confounding? Let's start with the first 2.
Associated with density, exposure of interest, and outcome of
Okay, and so those are similar concepts. Your confounder must be associated with the exposure, and it must be associated with the outcome. Needs to meet those 2 criteria. And what should it not be? Intermediate. It should not be intermediate step from causation, be in that straight line from exposure to outcome. And, you know, a good method for thinking about conceptualizing confounding, if you are asked to diagram confounding, You can call age your confounding variable and just say your outcome variable, your disease, your exposure, and have your have the lines point in both directions with your confounder associated with exposure and outcome. Questions about confounding? Remember, it's a type of error. It can cause spurious results. We often are not able to identify all confounding variables because we don't have the knowledge, we don't have the data that allows us to determine whether or not the variable is both associated with the exposure and the outcome. It is complicates our thoughts about the web of causation because sometimes we just don't have all the information needed for our web. Okay, interaction. That's the final concept that was introduced. And interaction involves two risk factors and their effect on one disease outcome. If the effect of one factor is the same within strata defined by the other, then there's no interaction. When the effect of one factor is different within strata defined by the other, then there is an interaction. And so let's go one more piece of additional information before we get into an example that will help to think about and to clarify what interaction actually is. The magnitude or direction of an association varies according to levels of a third factor. It is also called effect modification. And so when you are advancing through epidemiology and as epidemiology has advanced as a science, we've gone into what is called modern epidemiology, primarily originally defined by Ken Rothman. The term interaction is no longer used, and we begin using the term effect modification. So if you hear or read about effect modification, it is the same thing as interaction. As a discipline, we went away from interaction because it sometimes means something a little bit different in statistics or biostatistics, and we wanted it to be have a clear epidemiologic definition. We don't control for interaction. We just describe it and say it's there. There's nothing we can do about it. It's not going to, controlling for interaction does not strengthen our results, does not make our results more true. The truth is that interaction exists, and we just leave it there. But we want to know whether or not it exists because it helps us to think about the causal mechanism. It helps us to appropriately design interventions. It's helpful to know if an intervention is going to react differently or be accepted differently in one population or another. All right. An example of interaction. All right. Cigarette smoking and radon exposure are two possible risk factors for lung cancer. Okay. Cigarette smoking can lead to an increased risk of lung cancer. Radon exposure can potentially confer an increased risk of lung cancer. And so our question is there an interaction between cigarette smoking and radon exposure as we think about an outcome of lung cancer? If the risk of lung cancer from cigarette smoking is the same among those who were exposed to radon and those who are not exposed to radon, then there's no interaction between the two risk factors. Okay, so that's when we started out. Let me go back. Where we stated interaction involves two risk factors. Okay, so in our example, we have two risk factors. We have smoking. The other risk factor is radon. And we want to know if the disease outcome differs taking into consideration both of those risk factors. So we've got the two risk factors. If the risk differs in the two groups, then there is interaction. Okay, so if the risk of lung cancer and cigarette smoking is higher in those who were exposed to radon than those who were not exposed to radon, then there's interaction. Okay. So it gets very complex when you start thinking about what is going on. Now you need to, as you're designing your study, you have to think about bias. How can bias enter my study? What are my confounding variables? And will we have interaction? Statistical interaction occurs when the incidence of disease in the presence, once again, the presence of two or more risk factors differs from the incidence expected to result from their individual events. And so the story can be made more complex when we are dealing with multiple variables. We can run a model that includes interaction terms for 3 or 4 variables, and then, we have to include the terms variable A times B, A times C, B times C, and so interaction sometimes gets to a point where your statistical model no longer makes sense or provides you with any other additional information. And so right now we are maintaining our concentration, our thought about 2 risk factors, and make sure that we understand the concept of what interaction means when we have 2 risk factors in an outcome. We've done this before. We've calculated ratio of risks. What's a ratio of a risk? And then difference of risk. We've used both ratios and differences to compute various indicators of association. In terms of interaction, we are using ratios and differences to describe two types of interaction. And so we want to know, we may want to know whether or not we have an additive situation or a multiplicative. Okay, and that just means exactly what it is. Additive, we're adding risks, or we're multiplying, multiplying risks. Okay. We have a hypothesis that high alcohol consumption is associated with larynx cancer. Cohort study. Okay, so we have exposure on the left, a positive exposure, and a non-exposure, disease, not disease, and we have a total of 45 with the cancer of interest, 470 that don't have the cancer of interest, free of disease, 200 were exposed, and 315 not exposed, for a total population of 515. What pieces of information do we use to calculate the relative risk of exposure to high alcohol consumption? That look familiar? See where those numbers are coming from, what cells they're coming from. Okay. You've got your disease exposure over the total exposed, disease not exposed out of total non-exposed. It's a ratio. Take it one more step, you've got a relative risk of 3.15. How do you interpret that relative risk?
Those have been exposed, have a 3.15 times more likely to develop the disease.
Correct, correct. Always interpreted the same way, no matter what your exposure is. And what your outcome is. So as stated, persons with high alcohol consumption appear to be at 3.15, 3 times higher risk of developing cancer than persons without high alcohol consumption. Second question, we now want to know if this elevated risk is the same when we consider another risk factor. Okay, remember, we're looking at interaction. Interaction, we need to think about 2 risk factors. Our first risk factor is alcohol consumption. Now we're going to the next step, and we want to think about the second risk factor. And so with a stratified analysis, stratified by smoking status, we want to know if the risk of our outcome is similar and smokers versus non-smokers. So we take the same 515 individuals that we started with in the first 2x2 table, and knowing their smoking status, whether they're non-smokers or smokers, we've got, we can fill in two 2x2 tables with the same analysis. We can answer whether or not smoking modifies the relationship between alcohol consumption and cancer. In non-smokers, we find that the relative risk is 1.96. What was the relative risk when we did not include the variable of smoking? It's 3. Relative risk has changed. Look and see with the smokers, relative risk is 3. So what have we learned from this analysis?
If you drink and smoke, you're a lot more likely to get larynx cancer.
Okay. And we have something different is occurring in non-smokers versus smokers. We see the potential importance of looking for interaction. It provides us with additional information. So we had accrued relative risk of 3, the first relative risk that was calculated. And then we did a stratified analysis, calculated the relative risk in the non-smokers, about 2, calculated the relative risk in the smokers, and we find that the stratum-specific estimates are compared to see if they're different. They are different. They do differ. 2 is different from 3. And so this is what one would step through to determine if you have interaction between 2 risk factors. The 2 risk factors in this example are the alcohol consumption and smoking status. So we mentioned that interaction can be additive or multiplicative. You're using a risk difference. For additive, you're using relative risk for to determine whether or not it's multiplicative. Here is basically the sort of same information presented in a different type of table. You still have your 2x2 table here, and it's contained in these 2 columns here, whether or not you have a no-no, a no-yes, a yes-no, and a yes-yes. If you have additive, you're adding. Multiplicative, you are multiplying your the risk ratios. Additive, you're adding. So let's have, this is another example. Once again, we're looking at we're using a cohort study for our example, and risk factor is gender. On the left side, females and males. Outcome variable is depression, whether or not depression plus, depression minus, with a total of 513 subjects. Those 513 subjects distribute among the 4 cells, calculating your relative risk. A over A plus B, C over C plus D, with a relative risk of about 4.6, 4.5. Females appear to be 4.5 times higher risk of depression than males. However, is this elevated risk similar among young persons and older persons? What would you do to answer that question? Once again, you can use stratified analysis. The analysis determine the relative risk for younger population, however it's defined, relative risk for older population, using the same, how many do we have? 513 total subjects. 204 are young, 309 are old. Have now we're using a risk difference in the young, risk difference in the old, or relative risk of 2.8 or so in the young, and the prior slide that showed the total population, the relative risk was about 4.5. Now we have 3 or 2.8, and risk difference of very similar in the young versus the old. Okay, so different results from the first example. What would you say about interaction and gender and age by using relative risks? No interaction, because our relative risk is very similar in the young population versus the old population. Just a different way of presenting similar data. With your additive, you add, multiplicative, you're multiplying. So let's go back to this slide, because it's providing us 2 pieces of information. We discussed information about the relative risk, and using relative risk, we found that there was no difference. But let's look at the risk difference. The additive model. Is the risk difference the same in the young versus the risk difference in the old? Okay. So these are examples of how to step through a calculation of risk difference, the additive model versus the multiplicative model, provides you with information. For this example, older age increases the risk difference between gender and depression. However, the risk ratio is not modified by age. Okay, two different pieces of information. We're using different techniques for calculating the risk difference and the risk ratio. Provides us with different information. So some criteria for thinking about presence of interaction as we review the data from our studies and we're looking at our descriptive statistics. We often are using the technique of eyeballing our data. We're looking at patterns by a single variable. We might look at correlations. You might see how the correlations are distributed in stratum 1 and stratum 2, and so it's the technique of becoming familiar with your data and trying to determine whether or not you should go further in terms of testing for interaction. Remember, we don't control interaction, but if it's there, it does provide us with an important piece of information that should be included in our reports. It is, as stated here, it's useful information. It provides us sometimes the next step, information for the next step of our investigation, knowing that, gee, not only does alcohol consumption make a difference in our outcome, but oh gosh, it is acting differently in, or having a different influence on young versus older, having a different influence on males versus females. So important pieces of information that should be explored and are determined through the review of potential interaction. And then being aware that calculation and reporting of an overall or accrued effect is potentially leading, because you haven't gotten to that next step and saying, well, here's my crude estimate, but gosh, what you really need to know is it differs in males versus females, and that's what this statement is alluding to. So let's think about what we know about confounders. Characteristics of a confounder include, and go ahead and let's see what responses work best for this. Okay, we have a response. I heard B. Confounder is associated with exposure. Does everybody agree? I'm hearing questions. Is there something else? Is there another response? F is A, B, and D. Confounder is a known risk factor for disease. Confounder is associated with exposure. Confounder is not a result of exposure. So we've had 2 responses. We've had B, and then we've had F. Now, B is included in F. How many say B? How many say F? Okay, and the majority is abstaining. Right. You've got F is correct. Why is F correct? Yes.
I was thinking, like, for D, the confounder is not a result of the exposure. If you go back to the diagram we had, like, age isn't a result of physical inactivity. That's kind of how.
It's not an intermediate.
Yeah, that,
I'm sorry?
it's not an intermediate step between the exposure and the disease.
Okay. Meaning that D is explaining the intermediate step. So we know it's not that. Yes.
I'm confused by choice A. I don't know if it's just the wording that is throwing me off.
I think it's the wording that's throwing you off because throughout today I've been using associated with either exposure or disease.
Okay.
And so an association is also a potential risk factor for disease.
Okay.
Is that what was throwing you off? Maybe that wasn't.
Yeah, no, I think so. I'm just seeing it as like, I don't know, maybe I just needed to think about it for longer, I guess.
Okay. These will be available to you. Okay. Let's look at incidence rates for groups exposed to neither risk factor or to one or two risk factors. You've got factor A, factor B, and incidence rates are included in the 2x2 table. And so using the additive model of interaction, what is the expected incidence in persons who are exposed to both factors A and B?
20.
Okay, so how did you come up with 20? Tell us what pieces of information that you were given in the 2x2 table, what did you use to come up with 20?
The difference between 12 and 7 is 5. So if you add 5 to 15, you get 20.
Okay, that's one method. Did someone use a different method?
Same thing the other way. 15 and 7 and 12 and 8.
Mm-hmm. Okay. Who would like more information about how the additive model of interaction was used to calculate the expected incidence? Is it clear what numbers were used to you? Do we need further clarification? Everybody all set? Okay, we want more explanation here. How can you help your colleague here? What can you help your colleague by telling you at what point you get stuck?
Actually, I'm not sure why we're like calculating this way. Like we're subtracting 7 from 12.
Okay. Someone tell us about 7 and the importance of 7. What is 7? Mm-hmm.
7 is the
the incident rate when neither factor A or B is present. So it's kind of like the baseline in a way. So then, if I can continue, that's okay. So 12, when you have factor A involved, it adds 5 to the base. So, and then when you have factor B, you add 8 to the base. Is that, so 15 is 8 plus 7, right? So you've added 8. So if you want to know what they are together, if it says additive model, all you need to do is add those two together. I guess I got a little hairy on the end. Does that make sense? No.
The important thing is you need to get your 7 out of there, because as we've learned, 7 is the baseline rate. Okay, and so you've got your 12 and your 15. You add and you take out your baseline. Add, take out baseline.
Otherwise, you'd be counting the 7 twice.
That's correct. That's correct. Correct. Let's use the same pieces of data in the 2x2 table, and now go ahead and use the multiplicative model of interaction. And what is the expected incidence in persons who are exposed to both factors A and B? Okay, I've heard C. Let's now put a justification or explain what pieces of information you're using to demonstrate the multiplicative model.
Can someone write it on the board as they explain it?
Sure.
Because I'm having trouble following people's thoughts.
Okay. Who wants to write it on the board? Is there room over here? Okay. Can you see that? See if this works. Who wants to take the pen, the magic pen? All right, there you go, Elaine. And every time you write down a number, tell us why you're writing that number down.
Bless you.
So I did 12 divided by 7. So 7 like the baseline, right? So you want to find how you got 12. So that's
Okay. Now, remember, let me put this into context. Okay. With the multiplicative model, you're using relative risk. Okay? And these numbers in these boxes represent incident rates. Okay? For relative risk, we are dividing a rate divided by a rate. Okay, so that's the big picture. Okay.
okay. So you get 1.71 because you're looking for what times 7 gives you 12. So if you get 1.71, then now you're looking for what times 15 will give you the exposure for both factors. So 15 times 1.71 gives you exposure for factors A and B, gives you 25.7.
Can you go up to the slide before?
Ah, there you go.
Okay, so then
Here's the slide before.
so since you're doing additive rule, 7 plus what gives you 12? So it's 5.
Right.
Okay, so what are you going to do with 15 to find out exposure for both factors?
Okay, see, okay. We're good now. Okay. I was confused why people were like, I don't know. Anyway, thank you.
Okay, very good. And thank you for helping each other out. Good deal. So these are questions that you want to keep going back to, seeing if you're getting correct information. Put different numbers in the cells. The numbers don't matter. It's the approach. You're trying to think about exposed, non-exposed, disease, not disease, and how you use the information in A, B, C, and D cells. The way that you write the instructions to yourself using A, B, C, and D will be the same no matter what the number is. Think of them as instructions. When you call them formulas, folks then say, formulas scare me, I can't do formulas. They're instructions for how to get to the answer. So, when you entered the room today, what questions did you have? Yes.
I have a question, but not related to the lecture.
That's fine.
Is it possible for us to get the article for our critique sooner than the date given? Because I want to not have to do it right before the final and around Thanksgiving.
Okay. Do you want the article sooner? We can do that. That's easy enough. It's out there. All I have to do is change the date, and so the article will be made available to you today by tomorrow morning. That's fine. That's fine.
Good job.
Any other questions that you had walking into the room today, or any other questions? It doesn't matter. Go ahead.
Can you just give a brief example of self-selection bias?
Sure.
It's just the word self-selection throwing me off.
Okay. Self-selection is basically the decision that an individual makes to participate in a study or not participate in the study. Okay. In general, they've been selected already by the investigator. Okay, that's step one. Have they been sampled to participate? Then you need to go to whether or not you're going to be able to obtain consent. So self-selection, the example that we used, if the individual reads the consent form and the consent form says, this study we're going to learn more about etiology of lung cancer, and that individual has lung cancer, they may self-select to be in the study because of the influence of having the disease of interest.
Okay.
Yeah, it's just, it's that point when a potential study subject has the opportunity to say yes or no to be a participant.
That's where you get like more.
That's right. Or you potentially could. That's correct. That's correct. Or depending on what is required of participation, maybe it's more attractive to females or males or older versus younger folks. It just depends.
So it just doesn't represent the population.
That's correct. That's correct. It could not. It potentially might disrupt the proportions and be disproportionate. Correct. What other kind of questions? If not, I'm giving you extra time to review your materials. These are concepts that require thought and review and are not necessarily intuitive. Yes.
So I was just making sure, because on our syllabus, we only have 4 exercise listed. But then when I looked at D2L as the grading section, there's sections for like.
Don't look at D2L grading, we're not using D2L grading.
There's only 4.
There are only, sorry, for that clarification.
Okay.
There are only 4, there are 4 exercises, thank you for clarifying that, yes, only 4. And so you've got 3 now, we'll open up 4, and that's an article critique. Use your feedback to pass in a strong critique on that. And that can be turned in whenever you want. Your exercises go into Dropbox.